Okay, well, I'm going to go ahead and get started, and as folks join us, please just make sure that you mute your mics, although you're probably not on to hear that right now. So, whoops, I may break in and remind those of you that join us. So, anyhow, my name is Natalie Mazzullo, and I'm with the Nevada Geriatric Education Consortium. This is our geriatric lecture series that we provide for the community. It's our honor today to present today's program, which is When the Rubber Hits the Road, Driving Fitness in an Aging America, presented by Dr. Lisa Rosenberg. The Nevada Geriatric Education Consortium is committed to improving the health care delivered to older adults by providing education, information, and resources to healthcare professionals and faculty. Just a reminder, we are videotaping today's presentation, and I'd ask now that everybody turn their cell phones to vibrate. I know that's always my reminder, too, to do that. Also, if there are any residents in the room, please also turn your beepers to vibrate. The presentation today has been approved for 1 credit in continuing medical education, nursing, long-term care, and social work. So you will be getting certificates today of attendance for 1 CEU. All sites that distribute CEU should have the certificates ready for you when you turn in your evaluation today. Please remember that we no longer provide handouts at our programs, and you can always log onto our website. There's a half sheet in the Las Vegas site, but you can also just go online and type in UNR, a space, and the letters NGEC, and our website does come up. On the right-hand side, it'll say upcoming programs, and when you click on that, you can there's a link to the handouts for the presentation. They're generally posted 2 days before the presentation date. I would like to introduce a dear friend of mine. We presented nationally once now, twice, a couple times. Once or twice. Dr. Rosenberg is on our consortium. She is the geriatrician that sits on our consortium, and so we're really pleased to have her here today. She is, I know, very busy, and so we thank you so much for your time. Dr. Rosenberg is a board-certified geriatrician, and she also holds certifications in internal medicine and hospice and palliative medicine. Dr. Rosenberg obtained her medical degree from the Medical University of South Carolina and then completed her residency in internal medicine at the University of Pittsburgh. She completed a 2-year fellowship in geriatric medicine at Johns Hopkins Bayview Medical Center, during which time Dr. Rosenberg studied the role of specific genes in vascular responsiveness at the National Institute of Aging. Following her fellowship, Dr. Rosenberg returned to the University of Pittsburgh, where she performed research in urinary incontinence for 5 years, obtaining a certificate from the university's clinical research training program. During her final months in Pittsburgh, she acted as assistant director for the fellowship in geriatric medicine. Her interests are urinary incontinence, driver safety in older adults, adverse drug reactions, and palliative care. Dr. Rosenberg currently is with Touro University, Nevada, and she teaches preclinical courses in addition to seeing primary care and consultation patients at Touro University's clinic. It really is my pleasure today to have Dr. Rosenberg here. Thank you.
Thank you very much. Can you hear this? Is this coming through the mic? It's coming through the mic. Okay, great. Thank you, Natalie. So thank you for joining us today. This is an incredibly important topic, and I'll just take 3 slides to show you why. Clicker. Oh, good, it worked. Okay. So what we'll do today is we'll talk about some of the aging-related factors that place older adults at risk for unsafe driving and motor vehicle crashes. We will describe some of the driver characteristics that we should look for when we meet with older adults. Nevada is actually a mandatory reporting state. So it is in the bylaws of my medical licensure that if it comes to my attention, those factors come to my attention to the level that I'm concerned about someone's actual fitness to drive, I do have an obligation to act on that. But this actually goes much more broadly than the primary care doctor. So this goes to nurses and physical therapists and social workers and occupational therapists. And we'll talk a little bit at the end about the special role that occupational therapists can play. And then we'll go over some of the evidence-based screenings that we can do. Although there is a book that has been put out, and it's actually available for free online by the American Medical Association, that's called Assessing and Counseling Older Drivers. We do not really assess older drivers. We don't do the assessment. Our job as providers, and that's a PA or a nurse practitioner or a doctor or a social worker, we are able to screen, but we don't do the actual assessment. So I would like that to be a take-home message. And I'm going to go over screenings that can be done today and what the trade-offs are, because we don't yet have a gold standard, right? If I want to know if someone's thyroid works, I draw a TSH and maybe one other blood test. And if the TSH is a little bit abnormal, I might order a whole panel to put that in perspective and tell me what's going on. With whether or not an older adult is fit to drive, we don't, even a road test is not a gold standard. Putting an older adult in a driving simulator, also not a gold standard. But we don't do those. Those are assessments. So we do the screening. So this slide shows us, I'm going to come over here. So this is the number of crashes per mile traveled by driver age. So if we look, so 16 to 20-year-olds, they're kind of dangerous. And then over age 75, we see that the danger again starts to go up. It turns out that if we look at everybody 65 and older, the number one cause of death from accident-related injuries is falls. And if we look at everybody 75 and older, it still falls. But if we look at 65 to 75, the number one accident-related cause of death is injuries from motor vehicle crashes. And then it's just that, and falls only surpass this risk because the risk of falls goes up so dramatically after about age 75. So this next slide just shows us that the passenger vehicle fatal crashes involvement adjusted for mileage. So we see that the previous slide showed us, well, they're about as dangerous, if you will, as younger people. And then the next slide makes it look like, boy, we've got a problem. And I would like to mention early in this talk that I'm a big proponent of keeping older adults independent and driving. Okay, so if we can do that, that's what they want, that's what we as a society want. Older adults can much more effectively give back to society, babysit for their grandkids, volunteer in the community if they're driving. Right? So that's in everybody's best interest as long as the driving is still a good idea. So I don't want to be perceived as someone who's trying to get our older adults off the road, because that's not what I'm about. So we see that if we adjust for mileage, older adults by mileage have a much greater risk of crashes. And then this is the number of passenger vehicle driver death per 1,000 drivers by driver age. So this is driver age and driver death. And so we see that even younger adults in crashes, the death rate's not that high, and it rises a little bit as we get older, and then, oh my gosh, at 75 it goes way up again. And the reason for that is there are physiologic changes that when these older adults get into a crash, they're more likely to suffer a serious injury. They're more likely to need emergent surgery to repair whatever those injuries are. They're more likely to have intracranial bleeding or massive bleeding because, for one thing, that's more likely as we get older. And this population also tends to be on aspirin or Coumadin or Plavix, all these blood thinners that, that are justified. But when you're in a motor vehicle crash, it works against you. So we see that deaths go up with crashes too. So just the risk of dying from being in a crash, whatever seat you're sitting in a car, goes up as we age too. So the practical assessment, and this is just a study from a couple of years ago, determining an older person's ability to drive rests on the physician's shoulders, and this is in Canada. I would say that our responsibility is much broader than the physician's shoulders, because they're only, it's like 12 inches or whatever that is. So it was a survey of physicians in Canada, and they included neurology. That kind of makes sense because maybe somebody had a stroke or they have some mild cognitive impairment. Geriatric, that probably makes sense. Physical medicine or physiatry, rehabilitation. So these are people that are recovering function. And driving is really all about function. Rheumatology, so these people can have muscle weakness, they can have chronic pain. Pain is a distractor when we drive, orthopedic surgery. And it might make sense to all of us, well, if you broke your right leg, right, you shouldn't be, we shouldn't rely on you to effectively press on one pedal versus the other. But I have a patient who broke her right humerus and came in with me to follow up. And the orthopedic surgeon didn't really think about until I called him whether or not this lady should be driving. Except, if she broke this bone, might she be in pain when she does what we're supposed to do when we drive? So this study showed us that providers in Canada were not fully confident in their ability to determine a patient's fitness to drive. And they were, in fact, receptive to more education. And so part of the education is it's not just the geriatricians, it's all doctors. And part B of the education is it's not just doctors. It really is healthcare providers and even the direct care workers. So the Aging and Disability Services division that may interact with older adults sometimes more often than the doctor does, often more often than the doctor does, will say, wait, this person doesn't seem quite as sharp, or they're not walking quite as briskly. And brisk walking is one of those things that we want to see, and we'll go over that. So I'm hoping that this group is receptive to education. It really is on us. And in this state, it is really on us because it is mandatory. There are only 7 or 8 states that have mandatory reporting. So why does this fall into the hands of healthcare professionals? Well, for one thing, the changes in a person's ability to drive safely are related to the changes that happen with age, but it is not aging itself that makes someone unfit to drive, not at all. And it's physical and mental changes, which doctors are supposed to assess. If we think there's a lot of mental stuff going on and it's out of the scope of our practice, we might send someone to a neurologist or a psychiatrist or psychologist. We really are the first line to say, is someone doing okay? And then mainly self-regulation is not enough. So I've had patients, and most people you talk to, if they take care of older adults, there are patients that have said, well, but I only drive in my neighborhood to the grocery store and to my church, or I don't drive on the highway anymore. And these patients are saying this to reassure me about the safety of their driving. But in fact, if we look at all drivers over whatever age starting at 65, so over 65 or over 70, we look at everybody who's driving, and then we look at the subset of people who curtail their driving distance or radius or circumstance. The people that go, oh, but I'm only doing this and this. This group is the more problematic group. So now they're saying, but I'm in that group that's higher risk, so don't you want to assess me? That's actually what they don't realize it. So self-regulation isn't enough. These people who are self-regulating, it's probably in everybody's best interest that they self-regulate, but it's in everybody's better interest that we find out if driving is still a good idea. So what factors increase the risk of difficulty driving in older adults? So vision impairment, and states have their state-mandated acuities that are required, and many states also have an angle of vision, so you have to have a field of vision that's like 140 degrees. I don't know that that's Nevada's number, I'm just saying. So so if someone has what we call field cuts or restricted vision because they have glaucoma, that's quite relevant. Physical weakness or poor motor control, so we think of people that have had a stroke, people with muscle disorders, patients with Parkinson's disease, right? So we say, well, but he can still walk. And Parkinson's disease is tough because they may have a resting tremor, right? But then they go to do something and they can sometimes do it pretty well. So it's really, again, on a case-by-case basis. And then any problem with thinking or processing is really important to consider. So does doing math in my head, is that enough processing to decide if I should be able to drive home from this talk? We're talking about a whole different level of processing, right? So I just want to briefly go over, and I'm watching the time, so I respect everybody's time. So who can screen and who can assess? So we talked about that. So really it's the DMV staff who assess, and driving rehabilitation specialists, which are in most but not all cases occupational therapy specialists, occupational therapy practitioners with additional training and certification to specifically look at driving skills. They are qualified to get in the car with the patient. I'm not qualified to get in the car with my patient, and sometimes that makes me super relieved. Should we be doing age or capacity-based screening? Well, if we picked an age where we should screen everybody, the first thing that comes up is that's a rather ageist approach. There are no data that really point us to an age where that's sufficient, and it would be incredibly expensive because the truth is most older drivers out there who are still driving are safe drivers. So referring everybody above a certain age is just incredibly expensive and inefficient. What to do when a driver fails a driving test? In this state, I believe you can fail the DMV exam 3 times before they don't let you come back. But I don't think you're allowed to drive between the tests. What are the best criteria for evaluating outcomes? So for instance, if I send my patient for a driving test and they pass it, and then they drive for another year and they haven't had an accident. Or let's say I just screen them and they're kind of, I go, no, I think you're probably okay. And they drive for another year and there's no accident. Does that mean they were fit to drive? It's not, that's not a good test at all. I was in an at-fault accident 2 months ago. My fault, I got the ticket. Because there's always somebody at fault, right? Even if it's, even the police officer said, boy, those cones were confusing. The police officers were making fun of it. That's how bad it was. But it was my fault because it wasn't the fault of the other person, right? And I would have passed all these assessments and passed my DMV exam, I think. Okay. So what is the best? Is it not having an accident? Is it not getting a ticket? Is it the fact that the family's not concerned? Right? So what is the best way to evaluate outcomes? And that would be a whole talk in itself, the ways we can look at this. Is it crash risk by population? And then what are the domains that require testing and how do we evaluate them? And I'll show you that, but none of our tests, there's no gold standard here at all. So how is this screen different from other screenings performed? So I have a 60-year-old and I say, oh, look, you're due for a colonoscopy. Let me send you to GI. How is this screening different? Anybody? This is the interactive part. This is the screening. First of all, it's not limited to people with MDs or DOs or nurse practitioner degrees. This is the screening with the greatest public safety implication. The only other screen that even comes close, and I don't think it's as much, is screening for TB before we put someone in long-term care and assisted living. This is public safety. So let me back up and say that my patient can say, you know what, I really don't want a colonoscopy. Or a woman can say, you know, those mammograms are pretty uncomfortable and I have no family history and they've been normal for 50 years. How about you stop bringing it up? But this is the screening where I have to say, I can't just back off on this one too, which puts the provider or any of you in a more difficult position. So relevant physical domains, so we talked about vision. Acuity is important, and the visual fields, there are different ways to test that. An ophthalmologist can test it quite specifically with special equipment. But what we typically do is visual fields by confrontation. So I would have the patient stand and cover one eye, and I hold up and I'll say, you know, how many fingers in all 4, what we call quadrants. So up here, down here, and down here, those are the quadrants. There's very scientific, up here, up here. How many fingers? And we test in each quadrant, and then we do 2 quadrants together to make sure that when one quadrant is stimulated, the brain doesn't just pay attention to only one. Because we are only going to be a good driver if we pay attention to this, right? And then we do it.
My eyes just start getting too tired too fast.
Can I just get you to mute your system? Thank you.
Is that the equivalent of throwing fruit? Okay, so motor strength, which we think is important. It was more important before we had power steering. My first car didn't have power steering. So then you had to have what we call 5 out of 5 strength. But 4 out of 5 strength is considered adequate. So if I can give somebody a high five, pretty good. And if I can walk on my toes and walk on my heels, if I can walk on my heels and toes, or if I can hop on one foot, then I have 5 out of 5 strength down here. Okay, so that's really good. So we want 4 out of 5 strength, and basically, if someone seems weak to you and you don't know what the rating system is, it's probably worth sending them to their doctor because somebody shouldn't be that weak anyway. And then range of motion, and that's really important, right? Because we want normal ankle range of motion to press on those pedals and lift off the pedal, right? We want to be able to extend our leg to press on the pedal, too. We want to be able to reach for the seatbelt. So one of the things that we do is we ask our patients that I'm assessing, if I'm referring them to the DMV, I do a physical exam that's very specific to motor abilities to do this. So I want to make sure that the patient can put a hand here, put a hand here. And the other thing that I'll do is, oh, everybody's checking. The audience here is checking. But the other thing is I have the patient face me, and that you can say, well, but to check their blind spots, they should be able to do this and get to a certain number of degrees. I only care that the total neck rotation and trunk rotation is adequate to check the blind spots, right? So if someone has a fusion in their neck and they're not very rotatable, I don't care, as long as they can twist around to both sides and read the sign directly behind them on my wall, okay? So I have very functional ways of assessing range of motion. We know that's important. Now, cognitive domains are different because there's a lot to talk about. So vigilance is just paying attention, right? So if anybody had a big lunch before you came here, your vigilance might be trickling. So the ability to pay continued attention to the task and the language of the road. So what do all those signs mean? And then is English your primary language? Or if you're driving in another country, do you understand what those signs mean? So the language of the road is important. Memory. Short term is where am I going right now? And long term is how do I get there because it's somewhere I've driven 200 times. Right, so long-term memory is it's in there, the directions. And then working memory is I'm on the way to this place today, short-term memory. I know how to get there, long-term memory. Oh, and look, there's a detour. So now I have to access all these other memories about the other streets that are involved. Oh, wait, that's a one-way street. Can't go left there. Right? So that's working memory. How do I work through this while I'm moving a 1,500-pound vehicle or more? Selective and divided attention. So I'm paying attention to what the light is doing as I approach a light. I'm paying attention to the 8-year-old on a skateboard who may or may not be paying attention to me. And I'm paying attention to both while I drive and look for where my turn is. Right? Or there are also cars coming, and there's a car now in the turn lane, and he might cut across too. So I have to be able to manage all of that information. Visual, we talked about acuity, but there's also perception. And so one issue is that when we're driving, you might have a tree near a stop sign, and part of the stop sign is blocked by the tree, which, by the way, they try not to do that, right? That seems like a really bad idea. But there are times when some important road signal is obstructed because of something, construction or a tree that needs some attention. And our brain has to go, oh, that red thing that, I didn't mean to do that. I apologize. Natalie, how do you do? Did you do that or did I do that? Oh, okay, Natalie did that. So that red thing sticking out is a stop sign. So just because I'm only seeing a little part of it and I see the white rim, that's a stop sign. So whatever else I do and whatever the kid on the skateboard is going to do, I'm going to be stopping in a minute. Oh, here we go. And then executive, which is just planning and judgment and decision making, which is really the culmination of a lot of other cognitive domains. Oh, thank you. It's okay. So some of the red flags that we want to look for generally when we meet with someone, and we don't have to be a doctor. We can be a social worker. We can be, this can be someone at the DMV. So the DMV front desk staff in many states are appropriately trained to look for what should be of concern, okay? So inattention to hygiene or grooming. So are the buttons lined up properly or the button shifted on the button down, right? Or maybe one sleeve is buttoned and the other sleeve isn't buttoned. Difficulty getting into and out of chairs or up onto the exam table. And a very practical reason that that's important is that if someone needs to go get in a car, right, so they got to do this and shimmy over, but they have hip pain or knee pain or weakness or neuropathy, and they get in and they're not comfortable, they're not going to be focusing on driving. They're going to be kind of adjusting while they're moving this big vehicle. And people who aren't comfortable, people who are in pain, are distracted. It's just like being in an argument with somebody in the car, except that it's just, well, that's not comfortable. And then it's worse if it's obviously the right lower extremity that we drive with. Impaired gait, for a similar reason, we worry about mainly the function of the right lower extremity. Now, for people who have had a stroke that affects the right side, adjustments can be made to the car, and the patient completely retrained to function with the left lower extremity to drive the car. But that's a very special type of rehab that requires special equipment to change the way the car is set up. Not impossible, and it's not rocket science, but it's not something you want to do. You don't want to just instruct well, you should drive with your left foot now, so good luck. That's not quite how we do it. Difficulty with visual tasks. So someone might reach for something and miss. That's a big one. Or they might not recognize where the floor meets the wall because they have difficulty with depth perception, especially if they have very poor vision in one eye or vision only in one eye. Because we actually get our depth perception from having both working. And then poor attention, memory, and language. And then one of the red flags is someone who can't stick to their medication regimen for whatever reason. Except that that's a double-edged sword because we're not very good at picking up non-adherence. Right? My nurse goes over it when my patients come in. You're taking this, and I still get in, and they're like, "Oh no, I'm not taking that." "Oh yeah, I take that when I remember." So they don't come in with a sign that says, "I'm not adhering to my medications." What does that make you think of? That's like a whole separate process that we need to be concerned about. Are there questions? Because I also don't mind being interrupted along the way if somebody has a question. So some of the important screening questions: do you think you're a safe driver? And if someone goes, "I'm okay," that's not all that convincing. And do they ever get lost while driving? All the time? We'll talk after it. I'm just kidding. So, and are they going to someplace is it when they're going to someplace new, or is it when they're going to someplace they should know how to get to? Because, I mean, I have patients that have lived here for 40 years and recently started getting lost. That's a red flag. Let's see. Do you have any problems while driving? If they can tell you anything, maybe it's something that we can help them with. Have you had any tickets, accidents, or close calls? I think it's obvious why that, right? Because what goes along with driving fitness is following the rules of the road. Have you noticed any damage to your car that is hard to explain? And a lot of times the family members will say this. They'll say, I'm concerned about Mom because she keeps getting these dings on her car and she's not able to tell us how they happened. So is she not willing to report that she's bumped into things? Or does she not really understand that things are happening to her car while she's in it? But either way, we're thinking that's something to explore. And then who rides in the car with you is a double question. Because the first part of the question is, who rides in the car with you? And if the spouse is always with them, is that because they just like being together? Or is that spouse or friend or child acting as a co-pilot? Because really, one person should be able to drive the car without any physical or physical assistance or prompting. So, there's a stop sign up here, slow down. Do you see the kid on the skateboard? Right? Oh, the light's turning yellow, so you might want to slow down. Okay?
Another way, no one rides in the car with you, they don't think it's safe.
Absolutely. Oh no, absolutely. That goes along with the second part of the question. For the first part, we have co-pilot versus navigator. So even though we have GPS in my husband's car, and he's a former firefighter, so he is Mr. Safety and Caution. But when we're going to a new place, Lisa, can you stop texting on your phone? I'm not driving, so I'm texting on my phone. Or talking to the kids. He'll go, can you pay attention and look for Smith Street? So even though he has GPS, he wants me to navigate for him. He does not ask me to co-pilot for him. So there's a big difference between those two. And then the other part is, who rides in the car with you? No, I'm just by myself all the time. May or may not be a red flag. Some people prefer to drive. and their family lives far away. But if you are dealing with an individual who you know has children and grandchildren who live locally, a great question is, are you ever asked to pick up the grandkids while your kids are busy? Because if the children won't let the grandchildren in the car with the driver, somebody knows there's a problem, right? Usually, not always. I have patients that have gone back to the workforce because their finances changed and they've had to. But many older adults have enough time to help the family out. And if they're not being asked to help, I consider that a huge red flag. And if the child is in the car, in the room with them, I actually say, would you put your child in the car with your mom or dad? And if they say, oh, well, my children are grown. And I said, fine, if you had a 2-year-old great-grandchild, would you let your mom drive this child around? I'm sorry, I shouldn't point. That's a big question. And you can get a lot of information from the look on the individual's face with the answer. So if you are in a circumstance where you know there are little people in the picture, it's a very good idea to know if they're ever in the car with your driver. So these are factors that affect driver safety, and really these are the red flags. So family concern, and I've had patients that were referred to me, and they're not even trying to establish care with me. They have a family doctor or another geriatrician or somebody that they're happy with, but they want me to be the heavy and get rid of the driver's license. And they'll go, everything's fine, but we got to get rid of the keys. That's what they whisper on the way in. So family concern is huge. We talked about curtailing driving distance or situations, so not getting on the highway, getting lost, co-pilot. These are all repetitive here. Unexplained damage. And then the new one is difficulty with left turns. So it turns out people with cognitive impairment are pretty bad. If they're unfit, they're pretty bad at turning left because you're going across lanes of oncoming traffic. So that's a way a lot of those accidents happen. And it's important to ask about, if you're, and there are patients who will only take right turns. So if they need to go left, they'll go 1 block past and go right and right and right. And unless we ask about difficulty with left turns, they're just going to say, well, I don't like taking a left turn. It makes me nervous. But what if they only had a choice of a left turn, right? So we have to say, okay, can you handle most of the circumstances that would present? Medical conditions, if someone has had a seizure, I believe the rule is 6 months without driving, and they have to report, like a neurologist has to report if their patient's had a seizure. And this actually, it doesn't even matter if they ran out of medication. And the seizure disorder is truly controlled when they get their medications, but they just didn't pick it up in time. The rules say 6 months off the road. Stroke, that makes sense, but again, we can rehabilitate people. Diabetes can lead to peripheral neuropathy. I had an uncle who's not with us anymore, but he had such bad peripheral neuropathy he could not feel the pedal when he touched it. So, and then the other thing is any patient who's had symptomatic hypoglycemic episodes. So they get confused or dizzy or lose consciousness from low blood sugar. So we have to be careful with our patients who have diabetes. Cardiovascular disorders, people with abnormal rhythms or low blood pressure, even if it's transient periods, I'm very concerned about that. And then vertigo is one, because that causes a sense of spinning when we activate the semicircular canals in the ears. What do we do if we can't see we have a blind spot that we're supposed to check, so we do this. What happens to someone's vertigo? It wakes up. So it's actually really important to treat vertigo. Those people don't need to give up driving permanently. Vertigo is treatable 99% of the time, and not with medications, but with a good physical therapist. So we can treat them, and in 2 to 6 visits in a 2-week period, usually we can make the vertigo stop, right? So those people don't have to give up driving. They just maybe shouldn't drive to those physical therapy appointments. Sleep apnea. So there aren't hard and fast rules about a lot of this. A lot of it is physician judgment and physician vigilance about the issue, frankly. Sleep apnea is not something that is gets a lot of attention when it comes to individual driver's licenses. But it is regulated when it comes to commercial driver's licenses because people with sleep apnea are sleepy during the day. And if you drive all day, right, we've all been on the road on a long trip and you go, okay, so you grab the Diet Coke or say, honey, it's your turn to drive. But these people drive for a living. Musculoskeletal disorders, dementing illnesses. So we've talked somewhat about these. I think that's pretty clear why they are important. And then depression, because depressed people don't focus all that well. But if we look, these are the medications that can affect driving safety. And there are antidepressants along with anxiolytics, so anxiety-blocking medications, pain medications, all of these medications, huge number. So the ones that are not on the list that affect driving potentially, let's see, Tylenol and the NSAIDs like Aleve and ibuprofen. Anything that affects the blood pressure or the heart rate or motor movement, so either diseases for Parkinson's, medications for Parkinson's disease or medications that can cause Parkinsonian side effects. So there are medications that have motor side effects. So I'm not going to read you. Just know that those are big, and it's basically most of the stuff we prescribe. And even medications that are over the counter can affect driving fitness. Okay, so I want to just walk you through very quickly. This is the address or the assessment of driving-related skills, which is from the AMA's guide that was published for assessing and and again, we don't assess, right? We screen, but they wrote a book called Assessing and Counseling Older Drivers. They don't know I'm here bucking what they said, so don't tell. So visual fields by confrontation to make sure that someone can detect. And there are actually, there's a really cool computer program called Drivable. So if you search Drivable, it's a computer program that's proprietary. So you can't use it, but you can see what it tests. And one of the things that it tests is it has the individual taking this computer screen-based test, look at the point in the middle, and it sends stuff in from the outside, and the person taking the test has to push a button, the return key when they can see things come into their visual field. So it's not really exact, but there is a normal sphere, if you will, where people should be able to detect visual acuity. There are several ways to do this. Mostly it's done with the Snellen chart. This is the ETDRS is actually one that's intended for use with people with diabetes and possible retinopathic changes. So that's 2 out of 7. The rapid pace walk is a good measure of range of motion and strength and sort of vitality. So the patient just walks 10 feet and turns around and comes back. That's it. And if they can do that in fewer than 9 seconds, that's considered normal. So I'm very concerned when my patient, who I know is driving, came in, and she said that her pain was worse, and she was going very, very slowly. And I'm not trying to make fun. This is about how quickly she was moving. And I thought, well, how quickly are those legs going to work if she has to slam on the brake because there's an 8-year-old who's run into the street? This is serious business. And I also want to just interject here that a lot of my concern for older driver fitness is not whether they're going to cause an accident, but whether they have the defensive driving intent and the defensive driving responses to avoid an accident when a 16-year-old who has nothing wrong with them is being stupid or irresponsible. So I need to know that my patient's legs are going to work quickly in an emergency that they didn't cause. So range of motion, so we can talk about the neck and the shoulder and the fingers, so patients should be able to grip the wheel. For people who have had strokes or rheumatoid or arthritic changes that change the shape of their hand, again, the occupational therapist can make adjustments to the wheel so that it's easier to grip the wheel. So they can. I have a patient who had a brachial plexus injury and one hand doesn't work very well, so they put it's like a stick that sticks out of the wheel, and it's a place he can kind of hang his hand because his grip isn't. And then this guy's he's a retired Marine, I think. He's tough as nails. He's not going to give up driving. So we need to make sure he's safe because he's not giving it up. Okay, motor strength. So we talked about that. How do we test that? trail making test part B. The results of this are associated with risk of crash. And what this is, I think I'll show you that. But there's trail making test part B, which is a grid of encircled letters and numbers, the same number of letters and numbers, and they're all in order, but they're jumbled. And you instruct the patient to go from 1 to A, and then back to the next number, and then back to the next letter. And what they're doing is they're keeping track of 2 series of information, the numbers and the letters. So they have to go from 1 to A, and then take the line from the A to the 2, and then to the B. So they really have to do visual spatial, because again, the numbers and letters are all jumbled, so they're kind of constantly looking for the next one. And they're keeping track of 2 series. So it's fairly sophisticated. If a patient takes more than 3 minutes to do this, we are very concerned. I imagine everybody in here could do it in a minute or something. And it's not all the way to, oh, here it is. Okay. I'm sorry, I didn't realize it was the next slide. So we have, where's the 1? 1, where's A? A, 2, B, 3, C. And, you know, so they're not even set up so that from 3 you have to go, you know, around lots of numbers. It actually, it's more like a spiral, which the patient doesn't know. So they're not placed in the worst possible place. And this time, this 180 seconds actually allows for you to help them if they're like, and they just don't see it. They just don't see that like next letter or number. You can say, well, maybe up here, right? So you're not supposed to point and go, draw the line here. But you can guide them. And if they're going to, let's say they go from 3 and then C, and then they're going to go, oh, here's 5. And it's okay to say, well, but what number did you just connect to before the C, right? So you're actually able to help them. But with or without help, if it takes a patient more than 180 seconds, very concerning. I have a patient who I stopped her at 4.5 minutes. Yeah, and so I sent her for a driving assessment, and she was deemed fit to drive at that time. I wasn't very happy about it, but I also thought, again, I'm the screener. I'm not the assessor. So I didn't want her driving, frankly, in my neighborhood. But I didn't have the test that the driving rehab specialist does are better than what I can do because I'm just a screener. Yeah.
When was this? How many years old is this? Would you say this test B?
So trails. I don't know how old it is.
Interesting to me. Like, we had it for 10 years. Have we had it just a few years? So.
Well, I think it's been around actually a long time, but its utility in driving risk assessment, if you will, was first put out, again, in the AMA Assessing and Counseling Older Drivers Guide, and that was evidence-based, so there were some studies before that that would support it. And again, and it's also part of this whole address system. I honestly don't know how old this piece of it is.
Interesting. Just interested to see.
I don't know. It's a good question. I should know that. I should be like, oh, the birthday for the Trails B test is. No, I don't know. I'm sorry.
I'm asking hard questions. I'm sorry.
That's okay. So, and then there's Trails A, which is just numbers. And there's some debate about, do we let them do a Trails A first, just so they kind of see what we're doing? Or does that give them too much of a practice and too much of an advantage? And I don't really think it's an important distinction. I was very concerned going into the test. When I gave this test to my patient, she really had a hard time understanding the directions. And at 4.5 minutes, I cut her off. Okay, so then there's the clock draw test. So again, this shows visual spatial ability. The patient needs to think. Yes.
Hello? This
Yes.
is Reno Medicaid. We can't see the PowerPoint.
It's not up behind you anymore.
Oh.
Oh. You want me to wait?
Yeah, we can see everybody else.
Everybody wave.
Hello?
We're working on it right now.
Okay, thank you.
I have time, don't I?
You might have a minute. You know, I don't know where.
As David Rubin from UCLA Geriatrics, we were sitting at the American Geriatric Society conference, and he's like the chief of geriatrics at UCLA. He's a giant in geriatrics, but he was stuck sitting next to me, little old me, and we were wondering about the meaning of a word, and he picked up his cell phone and he said, "But it's knowable." So he picked up his cell phone. So how old is Trails B? Trail making test A and B.
We're trying very hard to find that screen setting.
Okay, thank you.
Oh, 1944? Okay. Thank you. So far I got back to I found a citation in 2004, so I was only going to be 60 years off. Okay. Oh, right. I went to Google, but Wikipedia is. Okay, that's a good point.
Can you see the PowerPoint now?
No?
This is Gardnerville. The slides aren't visible on the screen.
Okay, thank you. Do you have copies of the PowerPoints at your sites?
Yes.
Since we only have 10 minutes left in the program, can you please just follow along on your PowerPoint? And we will get this fixed. It's my understanding that there's something wrong with our touch screen, and it's not allowing us to go. Thank you.
Okay.
I apologize for the inconvenience.
No problem. Thank you.
Okay. Okay. And they have I think everybody has the PowerPoint in front of them, but so this just shows, obviously, the one on the right is not even a handwritten clock, but the instructions to the patient are draw the face of a clock, draw the face of a clock, put the numbers on the clock, and make the hands of the clock show. And the two times that are used are 10 minutes after 11 and then 2:45. And so if you look on the left, for those of you that can see it, 10 minutes after 11, and what they've done is they've made two hands of equal length, and we know that the hands need to be a different length. The minute hand is longer. And they point to 10 and 11. So the patient has probably lost some abstraction ability, which is, right, so we can think in the abstract, 10 minutes after the hour, so that would be number 2 on the clock. But this patient has lost some abstraction ability, and then they were distracted by the examiner saying 10 and 11. So this is how we end up with this. But you can learn all sorts of things from how people do their clock, because they might make a clock that's so small that nobody can actually get 12 numbers in there. So they might make a tiny little clock. It's also correct if the patient first places 12, 3, 6, and 9 correctly so that they can do their spacing. That's good planning ability. Many patients don't, and you can see that this patient didn't because 6 wasn't really at the 180-degree point. So we can learn a lot from clock, and together clock and Trails B are pretty good. But this whole address system was really designed to, if someone has a deficit in one area, that we should refer them. But if they have a range of motion problem and it's their left shoulder, which they don't need to put on a seatbelt to drive, right? You need your right shoulder to put on the seatbelt when you're driving. So this is not, this is an incredibly sensitive test. In studies, it has been shown to be 100% sensitive, but very nonspecific. So you'll end up sending a lot of people for a formal assessment that don't actually need to go. So the question is, can we do better? And this was a cross-sectional study that was published last summer they looked at patients age 60 to 90, and they looked at people they considered normal and people they recruited from a memory disorders clinic. And they said, how can we make this better? Trail making test B was most highly correlated with road testing, but only in the people with cognitive impairment. It didn't mean much in people who were cognitively normal because they all did pretty okay on the test. You had too many people in the group that did fine who ended up passing the test to say that there was any value in it. Range of motion and the rapid pace walk were also predictive on road testing. So how well someone can actually move their body in comfort and with a reasonable speed, and then how quickly they could walk, which makes sense, right? Because you need to be able to act quickly behind the wheel. They actually didn't even assess the visual acuity in this study because each state has its own mandated minimum visual acuity, and the visual acuity indicated as abnormal in the address is worse than most states' visual acuity requirement. So there was no reason to test that. And also motor strength didn't pan out at all as being important, as it turns out, even though I think we'd all agree that you need to be able to control the wheel if your car is skidding in the rain or hydroplaning. You still need to have a fair amount of strength to control the wheel, apply pressure to the brake, right? So intuitively, these things make a lot of sense, and they didn't pan out in this study. And the bottom line is, I'm doing this quickly. And then they also looked at two different maze tasks. This is it's not Snellen, it's another S word. This is, sorry, what is it on here? Shucks, I didn't have the name on there, I'm sorry. But this is a standardized maze. This did correlate somewhat with driving ability, right? Because if we're going to do a screening, we don't want to send everybody who's a little bit abnormal, right? Because you've met people. Not everybody's, there are people I meet who are not normal, but they're probably okay to drive. They're just off. So we can't have a test that's 100% sensitive and lose specificity. So they were looking for ways to make this test better. So it turns out including the maze test, and again, they allowed 180 seconds for this, and it took me like not 10 seconds maybe to do it in my head. But so anyway, so they looked at the maze task, and they looked at the mini mental state exam. Now, the mini mental state exam is a dementia screen. That's all it is. It's a dementia screen. But for patients in the cognitively impaired group, and it's interesting because in both groups, the groups that passed the groups that passed and the groups that failed the actual road test that was done to verify these, how does the person who does this well do on the road? There were people in both groups who got a 30 out of 30 on the mini mental, and there were people who still failed the driving test. Right? So even though it seems like this is a great way to look at all these domain orientation, registration, recall, right? So what street am I looking for? This was good, but it wasn't great. None of these are great. So what they said, So what they said is adding the mini mental state exam and the maze to the address and taking out the vision because the vision bar is frankly way too low to be considered reasonable. And then looking at the 10, I'm going to go back to this. Range of motion and the rapid pace walk makes sense. Now I think that, and they did say that there's value in Trails B, but adding the mini mental and the maze add value, and still our sensitivity and specificity are not great. So there's still clinical judgment. For those of you who are not primary care practitioners or specialists, and you might say, well, I'm concerned, there's nothing wrong with calling the doctor and saying, I'm really concerned. That's the ethically right thing to do. And let the doctor do the screen. If you're not comfortable administering the screen, or you say, well, I've only known the patient a couple of weeks, I don't really know if, right? You just might not be comfortable. There's nothing wrong with calling their primary care provider and saying, I'm concerned. This is a state where the doctor has to pay attention to that information. So approaching the issue, and I know I'm going really quickly, very important to be candid about this. If I see a patient with mild cognitive impairment, which is early changes in memory that don't qualify as dementia, I tell them that we have to be concerned about their driving safety. And I may do a screening and say, I think they're fine now, I'm not going to refer them. And if they stay at some people develop mild cognitive impairment and it never progresses to dementia. So for that fortunate group, they may be able to drive a long, long time. However, if I see changes in cognition or function, I tell them that this is going to be an ongoing conversation because I am obligated in my responsibility for public safety to pay attention to this. So I'm always direct. I never send a patient to the DMV as a surprise. As painful as it might be to tell somebody, it's worse to have them get a letter without being warned. Some people say it's good to talk about transitioning or retiring versus giving up the keys. And I talk to them about the good news that we're going to get either way. We're either going to get the good news that you're still safe to drive, or we're going to get the good news that you're not fit to drive and we figured it out before somebody got hurt. In my world, that's very good news. And I talk about how I do want them to continue to drive, but that it's a privilege and we have to make sure that they still qualify for that privilege. I've had patients' children assert to me that it is my mother's right to drive. She's been driving all her life. She's never had an accident. And one son went so far as to say, and if she dies behind the wheel, that is her right. And I was like, what about the other people in the community? While she's out there, we have to be a little more careful than that. So these are some important resources. CarFit is actually a program where occupational therapists can get together with a patient, and they'll make sure that the car fits the patient. Car fits when they're not in my office, they're just individuals. So they make sure that the car fits the driver. So, the stereotype is we have these little old ladies and men, and they're like this. Well, that's because they can't reach the pedal. So if we put pedal extenders on for these patients that are insisting on driving the big sedans, which are pretty safe to drive, actually, right? It's better to be in a sedan than the smart car. But if you're going to be in a car that big, you have to be able to reach the pedal. So we put pedal extenders. Now they can see over the wheel. If someone has neck problems or back problems, an occupational therapist can also help them get mirrors that you can buy at Walmart and have them properly mounted on the car so they can see the blind spot without checking around. Okay, so a driving rehab specialist. I'm just going to go over the upside and the downside of the DMV versus a driving rehab specialist. And I tell this to all of my patients. When the driving issue comes up and I'm concerned, it definitely makes the clinic visit longer. But if I just go, you know what, I really have to send you to the DMV and that's it, wow, now I'm just the bad guy. So I really want, first of all, I want them to have some feeling of choice in the matter. So I say the part we don't have a choice about is that we have to assess your fitness to drive. I have enough information now that I'm concerned. There's a little alarm going off in my head for one of many, many reasons. The upside to the DMV is that they're free. Are they really free? They're not really free. We pay for that in our taxes. But there's usually no additional expense. So when I send the patient to the DMV, and you'll see at the end of your handout, the first slide is the form that I send to the DMV. They will then send the patient a letter that says they need to come in for a driving evaluation, and they have to bring that form back that I have filled out. So if I refer a patient and they're mad at me about it, they cannot go to a different provider. Our DMV is very smart and insists that the doctor or the provider that referred the individual be the person who fills out the paperwork. Very, very important. I did have one patient who tried to circumvent, and they didn't let her do it. So the DMV is free, if you will, in the way that it can be free. They have the right to also say, they want to make sure that the car registration is up to date. They can actually insist on testing for the car, too. But the downside is you just get a pass or a fail. You just get thumbs up or thumbs down, and that's all the information you get. A driving rehabilitation specialist is almost never free. Well, no, let me back up. They're never free. They're almost never covered by insurance. There are very rare circumstances, and I don't know of any personally, that they would be covered by insurance. And the details of those exceptions are not important. But a driving rehabilitation specialist does an in-office assessment first. Then they, assuming they feel like it's reasonable to get in the car with this individual, they then actually do an on-road test. And the patient may get a thumbs up or a thumbs down, but they might say, and I've gotten reports that say, I'm concerned about this, the patient really needs an eye check, I'm concerned about their peripheral vision, and this modification needs to be done to the car. Or the rehab specialist might say, it looks like their reaction time is a little slow, and there are things I can do in my clinic as an occupational therapist that can help them with reaction time. There are cognitive exercises, motor exercises to speed that up again. Because just like our motor strength, just like our balance, reaction times need to be maintained, actually. So you can get a thumbs up or a thumbs down, or you can get a thumbs down with recommendations. And then you have someone who's invested in helping the patient and then lets the doctor know, looks like they're good to drive again. So I would love to field questions.
I have a question.
Oh.
So my question is, if I'm a social worker and I'm going into a home setting and I'm meeting with a client and I feel that there is some impairment, am I able to write up the DMV referral, or do I have to refer them to a geriatrician?
So it absolutely doesn't have to be a geriatrician. I believe that any healthcare professional can do that. Those forms are on the website, and they can be sent in by a neighbor and say, look, I live next door. I'm not trying to get use of their car. You know, when it's someone who's not a healthcare professional, the DMVs will also sometimes worry that there's secondary gain. Like, do the kids want mom not to drive the car so the grandkid can have the car, you know? But anybody can fill that out and fax it in and say, you know, this is my neighbor. I don't want anything to happen to her. But if you're a healthcare professional and you send it in, great. If you're not comfortable with, you know, you're just like, oh, I'm a little uncomfortable, then you can communicate that to the doctor or whoever the individual's primary care provider is. But the DMV wouldn't ignore that. They might contact the patient, but when the doctor sends it, and I'll tell you, when I fill out the paperwork, it actually, if you look closely, and those are PDFs, so you guys can expand them and save them, or you can go to the DMV website and read them, because they're bigger. It says what kind of restrictions should be, when I get the paperwork, well, when I send the paperwork in, it says what kind of impairment is there. And I almost always write, because I'm very sensitive to this issue, it is not clear that there is an impairment, but this patient has some memory change, and they need a road test. So I write the words road test. So there's no question about, will a written test cut the mustard? Because I don't care. I personally don't care about the written test at all. And then when they send it back, when the patient comes in with their form, there's another question: what kind of restrictions do you recommend? And I say, during the road test, the DMV examiner should determine what restrictions are appropriate. And there are patients who shouldn't drive at night because of poor night vision. And if a patient says, my doctor told me not to drive at night, otherwise I'm okay, if that's what their eye doctor said, that's totally fine. That's not a red flag for me, as long as they're abiding the daytime only rule. Yes?
Are long-term care administrators mandatory reporters?
I don't know. That's a really great question. I actually don't know. I don't think so, because you're technically not a healthcare provider. So I don't think that counts, actually. Does that mean that, and then the other thing is, what kind of long-term care? Assisted living. So you have people who are driving. Yeah. That's a tougher one. The other thing to know is that the states that are mandatory reporting tend to provide protections. There are actually states where not only most states are not mandatory reporting states, and not all states have rules that protect good faith reporters. So if you send in a note in good faith, then you should be protected from any civil counteraction, if you will. But if you know who this individual's doctor is, you could just call the, and I see patients in assisted living, and I know there's paperwork associated with it. Therefore, I know who lives in assisted living. So if I got a call from an assisted living and said, your patient so-and-so lives here, but we're not sure they're safe, I would make sure to follow that up at the next visit. Oh, so if you hold a license for your role, okay. I didn't know that. And you had a question, right?
Are there guidelines for when the mandated reporting, like, you must report within 3 days, or I guess can you expand a little on what the mandated reporting is?
Okay, so this is the way I do it, and the rule books don't actually have all the rules. So the rule books don't have all the iterations. When I see someone who I'm going to refer to the DMV, I fax it that day or the next day. I might get swamped, and then I have meetings all afternoon for stuff, but in my pile of patient stuff, and to me that's a big one. That's not yearly mammogram, that's public safety. The mammogram order I can sign in a couple of days. The other thing is, because I go over with my patients the choice between being referred to the DMV or being referred to a driving rehab specialist, I don't report to the DMV. I say, I want to see you back in a month so we can go over what the rehabilitation specialist said. I think there are 2 in Las Vegas. Deborah Hansen is one of them. And if they come back and they go, I think you're full of it, I'm not doing it, then I go, well, the other choice was to refer you to the DMV, and because we reached that level of concern, I now have to do that. So I make sure to follow up. So I don't interpret mandatory reporting as I report everybody if they're not, because if they're willing to see someone who's going to formally assess them and even provide them the opportunity to rehabilitate their driving, I don't need to involve the DMV.
So it's not a highly hospital like how to protect it.
No, which I believe is 48 hours. Oh, it's 24 hours, and that's, yeah, so, right. But the other thing is with elder protective services and abuse issues, the provider also has to say, can I even let this person go home to that environment? And I guess you could say, well, I don't really want this person driving. I've never had someone that I was so concerned about I wouldn't let them drive home. It was more like, this is just something, right? We don't have, I don't think of doctors or providers as having the right to take away the license. I mean, I don't interpret the mammogram that gets ordered. I just order the screen. So there's what I'm allowed to do, basically. Does that help? So it's not hard. If there's no, to my knowledge, there's no hour rule on it the way there is with reporting of concerns for abuse. Are there more questions? Okay.
Lisa, thank you so much. That was, I know I stepped out of the room a little bit, but I've heard this before. This is a fascinating lecture topic. I don't think that people really think about this from a health profession stand,
Right, and I like talking about this because providers don't think about it. I'm not the most knowledgeable person in the whole country. I know enough to educate people locally that this should be on our minds.
I really, I was pleased that we were doing this presentation because I do think it's a very important issue. I want to thank everybody for attending the program today. I want to apologize for any technical difficulties that we may have had, and we will work on getting that better in the next presentation. I would like to remind you that you have some evaluation forms to fill out, and if this is the first time that you've attended a geriatric lecture series, please also fill out the participant information form. The data is collected and reported in a group format, and it helps us receive our grant funding that allows us to provide these continuing education units for free. Thank you again for supporting the Nevada Geriatric Education Center, and please check our website often for the next program. We do have a program coming on June 19. It's going to be transgender in the primary care setting. setting. That program is in the evening. It will be a Thursday evening. It's June 19, and it's from 5:30 to 7:30. So please sign up for that if that's something that you're interested in. It has been approved for 2.0 CEUs for long-term care, marriage and family therapists, social workers, nurses, physicians, and physician's assistants. So thank you again. Lisa, thank you.